Welcome to the deep dive. Today we're zeroing in on something that you as family medicine residents here in Singapore will definitely encounter frequently. Diagnosing and managing chronic obstructive pulmonary disease, or COPD.
Yeah, it's a really critical area. COPD isn't just common, it's a major driver of illness and, sadly, mortality, both globally and right here.
Right.
And to really underscore its impact, just think about this. Back in 2022, the estimated annual societal cost per person here in Singapore was around, what, SGD $3,304?
It's significant.
Wow. That figure really does highlight the far-reaching consequences, doesn't it? And while we know COPD isn't, well, fully reversible,
No, unfortunately not.
the good news is that with proactive and effective management and primary care, you all really have the power to, dramatically improve your patient's quality of life.
Absolutely. You're right there on the front lines. And your ability to spot COPD early and manage it well, that's paramount to reducing symptoms and preventing those really debilitating exacerbations. So, to make this as practical and relatable as possible, we thought we'd walk through a pretty realistic patient scenario. And then we'll sort of break down the key clinical insights you can take directly into your practice. Sound good?
Sounds like a great plan. Let's meet our patient.
Okay, all right, picture this. You're a family medicine resident, and Mr. Tan Kwok Leong, he's a 65-year-old gentleman, is in your consultation room. He tells you, "Doctor, I've had this persistent cough for months now. It's getting harder and harder to breathe. I can't even manage, like, a single flight of stairs without stopping for air."
Okay. Mr. Tan, thanks for coming in today. Can you tell me a bit more about this cough? When did it first start bothering you?
Well, doctor, it began maybe about 6 months ago. Initially, it was just a dry cough, mostly in the mornings.
Right. And how has it changed since then?
Over the past maybe 3 to 4 months, it's become productive. I bring up a bit of whitish phlegm each day.
Yeah.
And the breathlessness, yeah, that's become much worse. At first, I only noticed it when I was, like, hurrying, but now I can't walk maybe 100 meters on level ground or climb even one flight of stairs without having to stop and catch my breath. It's really affecting me.
Do you find this happens at night as well? Does it wake you up?
Yes, sometimes I do wake up coughing, maybe once or twice a night. And I've been feeling, well, more tired lately, especially in the last few weeks. No fever or chills, though.
Okay.
And I haven't coughed up any blood or had chest pain, thankfully. But I have noticed I've lost some weight without trying. Maybe a few kilos.
Okay, that's helpful. Have you noticed anything in particular that makes your symptoms better or worse? You mentioned exertion makes the breathlessness worse.
Yes, definitely worse with any physical activity, for sure. And I work part-time cleaning at a hawker center,
Okay.
and I find it's worse there. Maybe it's the dust. I did try using a blue inhaler from my neighbor a few times last month, the one for asthma.
Right, the salbutamol inhale.
Yeah, that one. But it didn't really help much. Maybe just a little for a very short time.
I understand. This is all very helpful information, Mr. Tan. Now let's talk a bit about your past medical history. You mentioned you have high blood pressure.
Yes, doctor. Diagnosed about 10 years ago. I'm supposed to be on amlodipine, 5 milligrams once a day. But to be honest, I'm not very good at remembering to take it.
Okay.
I probably miss it about half the time, maybe more.
Right. Thanks for being upfront about that, Mr. Can. It's important we know. Have you ever been diagnosed with any lung conditions before, like asthma or maybe tuberculosis?
No, never. Nothing like that.
And what about your family history? Anyone in your family who has had lung problems?
Well, my father was a very heavy smoker. He died of lung cancer in his 70s. But no one else that I know of had any, significant lung issues.
Okay. And could you tell me a little bit about your lifestyle, your work, any habits like smoking?
Sure. I smoked about a pack a day from when I was maybe 23 until I was 63. That's a good 40 years, I suppose.
Wow. Okay. That's a significant history.
Yeah. I did manage to quit about 2 years ago. There was one of those health campaigns.
Good for you. That's excellent.
But it's been tough, especially when I get stressed. But no, I don't smoke now, and I don't vape or anything like that.
Okay. And your work?
Before I retired about 5 years ago, I worked in construction, general labor mostly, for over 30 years. Now, as I mentioned, I just work part-time as a cleaner at a hawker center, maybe about 15 hours a week. Like I said, it can get quite dusty there sometimes.
Right. That exposure is relevant. And your living situation.
I live alone in a small rental flat. My wife passed away about 5 years ago, and my son, he lives overseas. We don't connect very often, so yeah, I don't have a lot of social support, really.
I see. And your diet?
Oh, I usually just eat at the Honker Center where I work, or maybe nearby coffee shops. It's mostly, rice and noodle dishes. It's hard to afford many fruits and vegetables, honestly.
Okay. Any alcohol?
On weekend evenings, maybe, I might have a couple of cans of beer. Nothing excessive.
Okay. Thank you for sharing all of that, Mr. Tan. So, medications.
Mm-hmm.
You mentioned the amlodipine, which you take sometimes, and occasional paracetamol for aches.
Yes, that's it.
Any allergies to medications that you know of?
No, no allergies.
Okay. Now, before we move to the examination, I just want to understand what's going through your mind. What do you think might be causing these problems? What are your main concerns?
Well, like I said, my father had lung cancer, so that's a worry. Or maybe just weak lungs from all the smoking. My biggest concern is this worsening breathlessness. I'm worried I won't be able to work, or I might end up in hospital, and the cost of treatment is definitely on my mind, too.
I understand completely. And what were you hoping for from today's visit?
I was hoping you could give me maybe a stronger inhaler, something that actually works, and I'll probably need an MC for work.
Okay. Is there anything else on your mind right now?
No, doctor, I think that covers it. I really want to be able to breathe easier again.
All right, Mr. Tan. Thank you.
Yeah.
That gives me a very clear picture. Now, I'd like to proceed with a physical examination, if that's all right.
Okay, doctor. Role change. Host now describes findings as if observing. All right, so during the exam, Mr. Tan appears somewhat anxious. He's quite thin. Actually, his BMI is 18.5. You notice some slight use of accessory muscles when he takes deeper breaths.
Okay.
He speaks in full sentences, but pauses occasionally, to take a breath. His respiratory rate is maybe around 20 breaths per minute. And he seems to lean forward just slightly while seated.
Right, the classic tripod posture almost.
Yeah, sort of. Chest expansion looks symmetrical, but seems reduced overall. When you percuss, the note is resonant, maybe slightly hyperresonant throughout both lung fields.
Right.
And listening with the stethoscope, auscultation reveals decreased breath sounds bilaterally, and it's more pronounced at the bases. You hear scattered expiratory wheezes across both lungs, and the expiratory phase definitely seems prolonged.
Okay, typical findings. What about vitals and other systems?
His BP is a bit up, 114,585 mmHg, likely related to his poorly controlled hypertension or maybe just anxiety. Heart rate is 88, regular, no peripheral edema, no palpable lymph nodes.
Okay, thank you. So, Mr. Tan, based on your history and the physical exam findings, the next really crucial step is to look at some breathing tests. We call this spirometry. We actually have the results from a test you completed just a little earlier today.
Oh, okay.
Looking at these results, after we gave you a medication, a bronchodilator, to help open your airways, your FEV1, that's the amount of air you can forcefully breathe out in 1 second,
Right.
is 1.50 liters. That's about 60% of what we'd expect for someone of your age and size. Your SCC, which is the total amount of air you can breathe out after a disc breath, is 2.50 liters, around 75% of predicted. But, and this is the key number, the ratio between these two, the FEV1 divided by the FEC,
Right.
that ratio is 0.60.
As Mr. Tan, what does all that mean in simple terms, doctor? Is that bad?
Well, Mr. Tan, a ratio of less than 0.70, or 70%, after using that bronchodilator medicine, especially when we consider your symptoms and your long history of smoking, it strongly indicates that you have an obstruction, a blockage in your airways that isn't fully reversible. This pattern is very characteristic of a condition called chronic obstructive pulmonary disease, or COPD.
Yes, Mr. Tan, COPD. Is that like emphysema or chronic bronchitis? I've heard those terms.
Exactly, yeah. Emphysema and chronic bronchitis are the main conditions that fall under that umbrella term, COPD. It's basically a long-term lung disease that makes it difficult to breathe.
Yes, Mr. Tan. Oh, I see. I was quite worried it might be lung cancer, given my father's history and all my smoking.
And I completely understand that concern, Mr. Tan, especially with your father's experience and your own significant smoking history. It's very natural to worry about that. While smoking definitely increases the risk for lung cancer, the way your symptoms have developed over time and these specific spirometry results, they are much more typical of COPD. However, just to be thorough and to address your concerns, we will want to arrange for a chest X-ray. That will give us a clearer picture of your lungs and help rule out other possibilities, including cancer.
As Mr. Tan. Okay, so it's not asthma then? Because I tried that blue inhaler my neighbor gave me.
Yeah.
It didn't really work.
That's a really pertinent question. It's important to differentiate. While both COPD and asthma can cause breathing difficulties, they are distinct conditions. Asthma often starts much earlier in life, maybe childhood or young adulthood.
Right.
And the symptoms in asthma, they tend to fluctuate quite a bit, maybe day to day, often triggered by specific things like exercise, allergies, or cold air. Also, in asthma, we usually see a much more significant improvement in those breathing test numbers after using a bronchodilator. Your results didn't show that kind of large reversibility.
As Mr. Tan. Okay, I think I understand. That makes sense. So, what's the next step for me now, doctor? What do we do?
Okay, let's pause the role play here and unpack this initial encounter for our residents listening.
Yeah, good idea. That history Mr. Tan presented with, the progressive breathlessness, the chronic cough, the sputum production, and importantly, that very significant smoking history in someone over 40.
Absolutely.
That should immediately raise your suspicion for COPD. It's like putting the pieces of a puzzle together, isn't it?
Exactly. And he also mentioned his past work in construction and his current cleaning job. Those highlight potential exposures to dusts and fumes. It's a crucial reminder for all of you that COPD isn't solely a smoker's disease, although smoking is by far the biggest risk factor.
Good point.
So the first key clinical pearl here is really to maintain a high index of suspicion. Think COPD in any patient, generally over 40, presenting with those classic respiratory symptoms, chronic dyspnea, cough, sputum, maybe wheezing and a history of exposure to risk factors. Smoking, yes, but also occupational dusts, fumes, biomass fuel exposure.
Right. Now, moving to diagnosis, as we saw play out with Mr. Tan, it really hinges on three pillars, doesn't it?
It does. You need, 1, the presence of those risk factors we just mentioned. 2, the characteristic symptoms. And 3, crucially supportive spirometry findings. Specifically, that post-bronchodilator FEV1-FVC ratio of less than 0.7.
And that objective measurement with spirometry is really non-negotiable for confirming a COPD diagnosis, right? You can't just rely on peak flow meters.
Absolutely not. Peak flow is useful for monitoring, say, asthma, but it just isn't sufficient to accurately assess airflow limitation for COPD diagnosis. You need proper spirometry.
And it's probably worth reminding ourselves and you listening that there are certain situations where spirometry might not be appropriate or should be deferred, like during an active respiratory infection or perhaps in someone with very unstable heart disease.
Correct. You need the patient to be stable. Now, when we encounter a patient like Mr. Tan, even when COPD seems likely, it's also really important to consider other conditions that might mimic it, the differential diagnoses.
Yeah, we touched on asthma already. The onset is often earlier, symptoms are more variable, maybe allergies or triggers are prominent, and there's usually better reversibility on spirometry.
Exactly. But we also need to think about things like congestive heart failure. You'd be looking for other clues there, maybe orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, crackles on auscultation.
Right, and maybe request a BNP or an echocardiogram if you're suspicious.
Precisely. Then there's bronchiectasis, which often presents with large amounts of daily purulent sputum production, sometimes recurrent infections.
And tuberculosis, especially important in our local context here in Singapore. You'd look for systemic symptoms like fever, night sweats, weight loss, though Mr. Tan did have weight loss, which needs follow-up. Maybe a history of TB exposure.
Definitely keep TB on the radar. And then there are less common possibilities, but still worth considering. In some cases, things like obliterative bronchiolitis, perhaps related to past infection or exposure, and diffuse panbronchiolitis.
So that chest x-ray we discussed for Mr. Tan becomes quite important, not just for the cancer concern, but also to help rule out some of these other possibilities like heart failure or TB, right?
Exactly. It's a key part of the initial workup. It might show hyperinflation suggesting COPD, but its main role initially is often to exclude other significant pathology.
Okay, so once we've suspected COPD based on history and risk factors and we've confirmed it with spirometry, what's the next critical step in our assessment? We can't just stop there.
No. Absolutely not. The next vital step is a really comprehensive assessment of two key things: the patient's current symptom burden and their risk of future exacerbations or flare-ups.
Right. How bad are things now, and how likely are they to get suddenly worse?
Precisely. For someone like Mr. Tan, we need to dig deeper. How often is he breathless? How much does it really impact his daily activities, work, walking, stairs? How often does he need to use any reliever medications, even that borrowed one? We need to quantify that impact.
And the exacerbation risk.
We need to ask specifically about any exacerbations he's experienced in the past year. How many? Were they severe enough to need antibiotics or oral steroids? Critically, was he hospitalized for his breathing? The number and severity of past exacerbations are strong predictors of future ones.
And there are tools to help with this assessment, right? Like questionnaires.
Yes, absolutely. Tools like the COPD assessment test and the MMRC dyspnea scale, the Modified Medical Research Council scale, are really helpful. They give you a standardized way to quantify the patient's symptom burden. Mr. Tan mentioning he had to stop his walks and miss work clearly points towards a significant impact, likely a high symptom burden, maybe a CHE score over 10 or an MMRC of 2 or more.
Okay, so we've got the diagnosis, we've assessed symptoms and risks. Now, let's get into management. Where do we begin? What's the absolute foundation?
Without a doubt, the cornerstone of COPD management, and particularly crucial for Mr. Tan given his extensive 40-pack year history, is smoking cessation.
Even though he quit 2 years ago.
Especially because he quit relatively recently and mentioned finding it tough under stress. The risk of relapse is significant. We have to strongly, clearly emphasize that staying smoke-free is the single most effective intervention to slow down the progression of his COPD, to slow that decline in lung function. Nothing else comes close.
So it's not just about diagnosis, it's ongoing support.
Absolutely. We should use that ask, advise, act approach. Ask about his smoking status regularly, reinforce the advice to stay quit, and act by offering support, maybe connecting him with resources like Health Hub's I Quit program, exploring pharmacotherapy for cessation if needed, especially given his relapse risk.
Okay, number one priority, smoking cessation support. What other non-pharmacological strategies are really important?
Vaccinations are paramount, absolutely crucial. We need to recommend both the annual influenza vaccine and the pneumococcal vaccine following the current guidelines in the National Adult Immunization Schedule. This helps prevent exacerbations triggered by infections.
Makes sense. What about activity? He's quite limited now.
Yeah, regular physical activity is highly beneficial, even if it seems counterintuitive when someone is breathless. We should encourage him to stay as active as possible within his limits. But for patients as symptomatic as Mr. Tan, with that significant impact on daily life, we should strongly consider referring him to a pulmonary rehabilitation program.
Tell us a bit more about pulmonary rehab.
These are structured programs, usually multi-week, involving supervised exercise training tailored to the patient, education about COPD self-management, breathing techniques, nutritional advice, psychosocial support, the works. They've been proven to significantly improve symptoms like dyspnea, enhance quality of life, and increase exercise tolerance. Really beneficial for patients classified as GOLD, D, B, or E, the more symptomatic groups.
Okay, so smoking cessation, vaccinations, pulmonary rehab referral. Now, we also noted Mr. Tan mentioned unintentional weight loss. You flagged that earlier.
Yes, that's correct. Unexplained weight loss in COPD is a bit of a red flag. It can sometimes indicate more severe underlying disease, nutritional deficiencies, or potentially point towards other coexisting conditions, including malignancy, which was his concern.
So what do we do about it?
It warrants further investigation. That chest x-ray is a start. But we might also consider some basic blood tests like a full blood count, inflammatory markers, maybe renal function and electrolytes, just to get a broader picture and rule out other significant underlying issues. And of course, nutritional assessment and support might be needed if he continues to lose weight.
And one more non-pharmacological point, his adherence to his blood pressure medication.
Yes, we need to address that too. His poor adherence to amlodipine needs discussing. Emphasizing the importance of taking all his prescribed medications consistently is crucial for his overall health, not just his lungs. We need to explore the reasons for non-adherence at cost, forgetfulness, side effects, and try to find solutions.
Okay, so we've covered the absolutely vital non-pharmacological bases. Now let's talk about medications, the inhalers. What would be our initial pharmacological approach for Mr. Tan?
All right, so given Mr. Tan's significant symptom burden, remember, he can't climb a flight of stairs. It's impacting his work, suggesting a high C8 or MMRC score, and his spirometry showing moderate airflow obstruction. His FEV1, 60% predicted. We need to initiate regular maintenance bronchodilator therapy.
Okay, what type?
For patients with less frequent or intense symptoms, maybe starting with a single long-acting bronchodilator could be an option. However, for someone like Mr. Tan, who is clearly quite symptomatic on a daily basis, guidelines generally recommend starting with dual long-acting bronchodilator therapy. That means combining a LAMA.
A long-acting muscarinic antagonist.
Exactly, like tiotropium or glycopyrronium
Right.
with a LEBA.
A long-acting beta agonist like salmeterol or formoterol.
Correct. This LAMA-LABA combination provides greater bronchodilation and symptom improvement compared to using either agent alone. These long-acting medications work over 12 or 24 hours to keep the airways open more consistently, helping to relieve his persistent symptoms and improve his baseline breathing.
So that short-acting blue inhaler he borrowed from his neighbor, the salbutamol, that's not going to cut it for daily management.
No, that's right. He will definitely still need a short-acting bronchodilator like salbutamol, a SABA short-acting beta agonist, available to use as a rescue medication. for quick relief when he experiences sudden or worsening breathlessness, like an attack.
Okay, so maintenance therapy plus rescue therapy.
Yes, the LAMA-LABA combination forms the foundation of his daily maintenance treatment. And it's worth noting for residents in Singapore currently, LABA-only inhalers aren't available as monotherapy for COPD. They're always prescribed in combination, usually with a LAMA and a single inhaler, or sometimes with an inhaled corticosteroid.
Right.
Which brings us to the next question. What about inhaled corticosteroids, or ICS? Should we consider adding those to Mr. Tan's treatment right from the start?
That's a key decision point. ICS can be very effective for certain COPD patients, but they aren't indicated for everyone, and we don't typically start them unless there's a specific reason.
And what's that reason?
We generally consider adding an ICS, usually in combination with a LAMA and a so-called triple therapy, for patients who experience frequent exacerbations, say 2 or more moderate exacerbations per year, or at least one severe exacerbation requiring hospitalization,
Okay.
and LAD who also have evidence of underlying eosinophilic airway inflammation. This is typically indicated by a blood eosinophil count.
Ah, the eosinophils.
Yes. A count of, say, 300 cells per microliter or higher is generally considered a good indicator for potential ICS benefit in terms of reducing exacerbations. Some guidelines suggest considering it even with counts above 100, especially if exacerbations are frequent.
So for Mr. Tan, he hasn't described frequent flare-ups in the past year, and we don't have his eosinophil count yet. Exactly. So based on the information we have now, initiating treatment with the dual LAMA-LABA therapy seems like the most appropriate first step for managing his symptoms. Adding an ICS right away probably isn't indicated and would just expose him to potential side effects unnecessarily.
And what are those potential side effects of ICS we need to be mindful of?
Well, common ones include oral thrush, so good mouth rinsing after use is important, and maybe a hoarse voice. More significantly, there's an increased risk of pneumonia associated with ICS use in COPD patients. So we generally avoid them or use them cautiously in patients with a history of recurrent pneumonia, very low eosinophil counts, or perhaps coexisting conditions like bronchiectasis or mycobacterial infections.
Okay. So checking his blood eosinophil level at a follow-up visit seems like a good idea to help guide future treatment adjustments if his symptoms aren't controlled or if he starts having exacerbations.
Absolutely, it's a useful biomarker to have.
Now, we have these great inhalers, LAMA-LABA combos, rescue SABAs, but they're useless if the patient can't use them properly, right?
Oh, absolutely. You've hit on probably one of those critical and sometimes overlooked aspects of management, inhaler technique.
It seems so basic, but it's so important.
It cannot be overstated. The effectiveness of these expensive and potentially life-changing medications hinges entirely on the patient getting the drug into their lungs correctly. So at every visit, you need to assess Mr. Tan's inhaler technique.
Not just the first time.
No, every time. Technique can drift. You need to provide clear education, demonstrate the correct steps yourself, and then this is key, have the patient show you how they use it. The teach-back method.
And there are different types of devices, right? MDIs, DPIs.
Yes, there are various types. Metered dose inhalers, MDIs, which often require coordination or the use of a spacer device. Dry powder inhalers, DPIs, which require a forceful inhalation. And soft mist inhalers, SMIs. We need to choose a device type that Mr. Tan can physically use effectively, considering factors like his inspiratory flow rate and manual dexterity.
And make sure he knows which is for daily use and which is for rescue.
Definitely. And also, crucially, remind patients not to use multiple inhalers containing medications from the same class, like 2 different LABAs or 2 different LAMAs, to avoid potential overdose or side effects. Check what they're actually using.
Okay. So let's circle back to Mr. Tan's specific concerns, his ICE ideas, concerns, expectations. How do we specifically address those? His worry about lung cancer, his need for symptom relief, and his financial constraints.
Right. We need to tackle those directly. For the lung cancer fear, we acknowledge his father's history and his own smoking risk, but gently explain why his current presentation, the symptoms, the spirometry, points more strongly towards COPD right now. Reassure him that the chest x-ray is part of the plan to investigate further, and specifically look for other things.
Address the fear, but ground it in the financial concerns. That's a real issue for many patients.
It really is. We need to acknowledge his concern about cost. We should actively explore if there are any subsidized medication programs he might be eligible for through polyclinics or hospital schemes or other financial assistance options. Being proactive about this can make a huge difference to adherence.
And finally, his expectation for an MC.
Yes, providing him with a medical certificate for the time he's been significantly unwell and unable to work due to his breathlessness is certainly appropriate and part of addressing his needs.
Okay, so we started him on treatment, addressed his concerns. What about follow-up? When do we need to see Mr. Tan again?
We should schedule a follow-up appointment relatively soon,
Yeah.
perhaps within, say, 2 to 6 weeks.
And what are the goals for that visit?
Several things. We need to assess how well his symptoms, the cough, the breathlessness, are being controlled with the new Lamalaba inhaler. Ask about his rescue inhaler use as you're needing it frequently. We absolutely need to recheck his inhaler technique, address adherence to the new medication, review the results of any investigations like the chest x-ray and blood tests, including those eosinophils. And based on all that, we can then adjust his management plan as needed. Maybe he needs more education. Maybe a referral to pulmonary rehab needs reinforcing. Maybe treatment needs stepping up or down later on.
It's an ongoing cycle of assess, review, adjust.
Precisely. COPD management is dynamic, not static.
That's a really comprehensive walkthrough of how to approach a patient like Mr. Tan, from initial suspicion right through to follow-up. So just to summarize for our family medicine residents listening in, what are the absolute key clinical pearls, the main take-home messages when managing COPD in primary care?
Okay, key takeaways. First, always maintain that high level of suspicion for COPD in the right context. Individuals, usually over 40, with relevant respiratory symptoms and a history of risk factors, especially smoking. Don't miss it.
Right.
Suspect it.
Second, confirm the diagnosis with objective spirometry. You need that post-bronchodilator FEV1 FVC ratio less than 0.7. It's essential.
Confirm with spirometry.
Third, once diagnosed, thoroughly assess the patient's current symptom burden using tools like CE or MMRC.
Right.
And importantly, assess their risk of future exacerbations based on their history.
Assess symptoms and risk.
Got it. Fourth, prioritize non-pharmacological interventions. These are foundational. Smoking cessation above all else. Appropriate vaccinations, flu and pneumococcal. And strongly consider pulmonary rehabilitation for symptomatic individuals.
Non-pharm first and always.
And finally, fifth, individualize the pharmacological treatment. Start usually with LAMA or LAMA-LABA based on symptoms. Use ICS judiciously based on exacerbation history and eosinophils. Always provide rescue medication. And critically, ensure proper inhaler technique. Individualized meds, check technique, perfect.
Yeah.
And it's so important to remember, like you said, that managing COPD is an ongoing process. Regular reassessment of symptoms, exacerbation history, and especially that inhaler technique is absolutely vital for providing optimal long-term care.
Exactly right. It requires commitment from both the patient and the healthcare team. So, for all of you listening, really think about how you can integrate these key insights into your daily practice. By focusing on early diagnosis, a comprehensive assessment, and a patient-centered management approach that includes both non-pharmacological and pharmacological strategies, you can truly make a significant difference.
You can improve the lives of your patients living with COPD and help reduce the considerable burden of this chronic respiratory condition in our community.
That's the goal.
Well, thank you for tuning in to the Deep Dive. We really trust this detailed exploration of COPD diagnosis and management has been valuable for your clinical practice. Until our next Deep Dive, keep up the great work.